He deferred to you.
Oh, okay, sorry. When it comes to the like relevant sensory data aspect of it, would DBT or more of like a body somatic type of therapy be helpful to with these clients to be able to work on that part when it comes to actually like understanding their senses and building the trust with it? So would that fit with this model like together, or would one be prioritized over the other?
I think it could be fit together. So the question was with people who are having difficulty connecting to sort of reality sensing cues, their five senses experience, would applying some other somatic therapy or DBT intervention to build up those skills be useful? I would say maybe. Again, we have to consider how the client interacts with reality sensing outside of their OCD. If they do so normally everywhere else, then we don't need to teach them new things. They already do it, they're just not doing it here, and then we need to figure out why. If someone's got a global issue with using sensory information, detecting sensory information globally, then maybe it makes sense to go, we need to build that skill first. Just like you might say someone has a global difficulty with regulating emotions. Not just in OCD realm, across the board. You might need to engage that process of learning before we help you in this way. That'd be true for ERP as well. Any other questions?
I have a question. So, if I understand correctly, ICT developed initially to address overvalue aviation. So, and now we're saying that we only use it for OCD. OCD is not transdiagnostic, it's only OCD specific. But I was wondering if it could be used off-label for overvalue aviation. Like if we have a client who is absolutely convinced, and they can give you all the evidence based on anatomy that they are worthless and they're terribly depressed, would it be, I don't know if there's any research on that, but would it be something that you could venture into?
I don't see why not. That's a clinical decision at the level of you and the patient. Right, so whether EPA would be like, that's an empirically supported use of ICBT or not, probably not. Although every trial where they measure outcome variables, BDI too is used, and it always goes down significantly. But that might be because the OCD went down. So it's a chicken or egg, right? So it's never been used with just depression in a clinically controlled way, to my knowledge. But that doesn't mean it wouldn't be helpful, right? We see the same application of rumination to major depression. We know rumination is a transdiagnostic mental process. We see it with eating disorders, we see it with major depression, post-traumatic stress disorder, generalized anxiety, and we know it can be really helpful to address that issue. I don't see why inferential confusion would be any less transdiagnostically valuable, and therefore a clinical decision. But if you measure it, right, oh, this person has more than 10 points on the ICQ, they have an 80. Well, 92 is the cutoff for OCD, but 80 is still significant. If it's applied to sort of dimensions of depression, I don't see why you couldn't use it. But you're right, it would not be considered first-line treatment.
But it makes it logical to you to go with that.
I would think so. We'll take one more question. Make up a question.
I don't know if this is more of like an answer type of question that you're going to get to this, but I think the question you're coming back to is like, how do you make the decision as a clinician of when to use ERP and when to use ICBT? Like I was asking you before we started, and you said that it was 75-25% split of who you do ICBT and ERP. But like, how do you come to that conclusion? And I guess my other question is like, if you start ERP and it's not going well, and at that point you use to stop and reassess and say, let's switch tacks into ICBT, and then how does that frame?
Did everyone hear the question? When do I do ERP versus ICBT? Is there some way to sort of parse that out? It's a really big question, and I think it depends on your willingness to sort of make your own clinical assessment with the client rather than following some hierarchical standard set by the APA. And then a lot of them have to do with insurance companies. And am I going to go in front of a board? I have to defend my actions. My own personal opinion on that is, ICBT, when explained to the client, given an example, and then ERP will explain to the client and give very fair examples in which one straw man any approach. Which one do you think makes sense to you? Which one do you think you'd like to try? Now, I do think it's a little bit of an unfair fight when you say this one doesn't involve in vivo exposures that gets you upset. But the other one does. So it's a little bit of an unfair fight. But not everyone's going to take ICBT. I've explained it before, and some people think that's just too much thinky, and I just want to do so. Right? Okay. If you're a doer, let's do ERP. But that's, if we're looking at sort of, is there any data for like when you should choose ICBT first? Nothing conclusive. There's some hints. One would be overvalued ideation, right? That's what it's developed for. So people with high levels of overvalued ideation, so if you give them the OGUS and you get a score of 6 or higher, ERP tends to have a hard time with those people. And there's data to support that. That's not my opinion. But ICBT addresses that quite well. All of their trials have shown that it works better on people with overvalued ideation compared to the control arm, which is CBT with ERP. And I believe the non-inferiority trials that are being wrapped up now show the same thing. So that's one indication, high levels of overvalued ideation. The client just outright refuses exposure. Okay. I'd like to offer my client something other than come back later. Right? It's kind of like someone says, do you speak this language? No, I only speak English, so come back when you learn English. It's a little bit, doesn't feel right. So if they refuse or they've dropped out of treatment before, I think all that's legitimate. Or if you just want to see that the client seems to connect with them and give it a whirl. It's a safe treatment. I don't think it's the same thing as celery juice or, how other people might want to characterize it as somehow potentially dangerous because I have 30 RCTs. It's kind of silly. Is that a long-winded answer to your question? All right, let's move on. This took me a really long time. I'm not so great with PowerPoint. My entire presentation started on Canva because I'm like, I'm going to try this new Canva. And then I realized I didn't know how to use it. And Marla was like, we need your slides. 3 weeks before the presentation, I'm like, screw it. We're doing PowerPoint. So I could be the kind of person who is, and then you insert your catastrophe here. It's a catastrophe because it's not who you want to be. It's the exact opposite of who you want to be. It terrifies you. And here are just a few examples of things clients have said to me. I could be the kind of person who is reckless, disgusting, impulsive. You see impulsive with harm stuff a lot? I could just lose control of this. I'm just sad people. Right? I'm fragile. I'm the kind of person who's just fragile or out of control, negligent, irresponsible, unprepared, immoral, stupid, oblivious, careless, irresponsible. I may have repeated some. And these are just a small spattering of what clients can come up with. So the whole point of finding the fear of possible self is to have it in the client's language. What is your brain telling you? Not what am I telling you? What's your brain telling you? And I might give them some prompts if we're having a hard time. And again, all of these are things that you aren't. You aren't this person. And they're going to say that there was that time, right, where I did this thing, and then there's another time where I did this other thing, and then we help them understand. Well, do you see how that's also part of inferential confusion with the pop hole, with the diaper changing, or with the public door handle? It's all part of the same process, isn't it? You're taking out of context information, you're kind of shaping it like clay so that it fits your conclusion about who you are. And that's not usually how we want to arrive at conclusions. Conclusions aren't decided ahead of time and then supported later, right? We follow evidence and we come to conclusions. That's how we ought to be doing things. As a matter of fact, that's how we actually do things. We just don't explicitly think that that's how we do things. So we want to bring all of this into the awareness. A lot of this can be done by working off theme. Again, for people who find it difficult to apply this to their own OCD theme, might resist this treatment at first. I've had that experience a few times. And I say, okay, let's work off of these case vignettes people have completely made up. And I'll send you these home for homework. Right? So you have client A, B, C, and D. I want you to sequence this out, find the doubt, right? And then circle all of the different reasons why their doubt felt real to them. And then come back and we'll talk about it. We do that for a session or two until they realize that's mine too. Now, we're not cured yet. That's just session one, right? But it opens up the door that maybe I'm doing something similar to these other cases of OCD. Now, you can't see this. And that's unfortunate. So let me try to explain this to you. Top area says disrupted self-identity formation during a critical period, i.e. parenthood or early adulthood. This is where we might call it vulnerable self. This is the area where you are reflecting on a sense of self because it is reasonable to do so, either developmentally or something in your life has changed. And then that information is now being filtered down into inferential confusion. It's being selectively pulled out. So who I am is being pulled out, and an inferentially confused narrative is being started. So down here, you see the fear possible self start to form. And this little guy off to the side just talks about basically inferential confusion processes filtering into it. And it creates a hypervigilance to here and now circumstances. So why would someone be prone to POCD, contamination OCD, existential OCD? Because their fear possible self has biased them towards those kinds of moments. And once those moments show up, you're already prone to inferential confusion because you were already in it. Your fear possible self was already there. And then that trickles down to the rest of the sequence. So this is the working model in one of the newer publications on feared self formation and inferential confusion. So I think it's Dr. Long is doing experimental studies that show that there actually is causal relationships between feared possible self and OCD development. And what we know tends to cause feared possible self is inferential confusion. So we actually have mechanistic data that shows feared possible self, as it's developed by inferential confusion, is causal to OCD. It's not the only cause, it's just causal in one way. We need much more data to feel really certain about that. But conceptually and clinically, it's very valuable. What's my time?
It's 25.
About 35 minutes.
35 minutes? Let's go to the next one. I'm just going to show you a little peek behind the door of some of these modules. We're not going to go into it. But hopefully you're so intrigued by this wonderful presentation that you're like, I'm going to go spend a lot of money on training. But I won't benefit from that because I don't provide formal training. Other people do. So module 1 we've already talked about. Module 2 I've mentioned before, which is where we let the OCD speak for itself. Give me all your reasons. Why is this conclusion reasonable? Not tell me what you think I want to hear. What's the OCD say? Then we go to module 3. We help them understand that none of this exists in a vacuum. Your reasons are not standalone line items on an Excel spreadsheet. They are woven into a narrative, which gives it a reality value. That narrative is what creates the veil of credibility. Trademarked. I came up with it. Module 4, feared possible self. Why this theme and not that theme? Next slide. Module 5 is all about trying to help you understand where it is that it came from. Obsessional doubt and normal doubt come from different places. One comes from reality in the here and now through 5 senses. The other one comes from your mind and possibilities. Do we agree on that? If the answer is yes, we agree on that. Then we go into Module 6. If we understand where it came from, and we understand all the justifications are not in context to reality, what implication does that have on its truthfulness in the here and now? It means it's irrelevant, right? If it's irrelevant, then maybe I shouldn't be using this form of reasoning. I shouldn't be biting this hook and going into this. I should choose the other fork in the road. Module 7 is the bubble. This is an experiential exercise that we help the client learn to spot the thing that hooked them and pulled them into this OCD narrative. And it causes them to cross what we call the bridge between reality and imagination. What was that thought? What was that experience? What was that story that pulled you into it? Can you pause for just a minute, self-reflect? Where was I when reality was present? What was I detecting? Where am I now and where am I headed? It's kind of like an equivalent. This might be act and the choice point, right? There's a choice point. If we slow down and just realized you could go this way or you could go this way. You could make a towards move, you could make an away move. If we keep going into the story, if we keep believing these possibilities over reality, we're going to end up exactly where we always end up, on OCD Island, trying to figure out how to win the game. Reality sensing, I mentioned this already. This is not reality testing. That's a cognitive appraisal model use of behavioral experiments, reality testing. And this is not exposure therapy. Exposure therapy, as it's applied to OCD and anxiety disorders, requires an excitation of the autonomic nervous system so as to learn fear extinction through habituation. Those are really big words that just mean you get used to the stuff that scares you if you stay in it long enough. So exposures are usually prolonged, right? 30, 40, 90 minutes. We usually need to see some form of habituation either in or between session. Even in the inhibitory learning model, the disconnect between the violation of expectancies, the greater the disconfirmation, the stronger the behavioral learning, which means the more you engage in a situation that you highly predict to be terrifying and uncontrollable, the bigger the learning is. So even in that model, we're seeing that people need to have some form of excitation, some form of distress tolerance, which presumes you're distressed. Here, by the time we get here, there's no requirement to be distressed. Being not anxious is not a signal that you're doing it wrong. Being not anxious might be a signal that you're seeing through the lie. And we just need to get you to do things in those moments that were previously obsessional and now do it normal. How would I normally close my door and lock it? Well, I wouldn't stare at it for 3 minutes and then ask my friends for the next 10 miles if they thought the door was locked. What would I do? I would know I heard the click. I would test the door once, it's locked, and I would go about my business. That sounds like exposure. But there's no reason to tolerate not knowing when it gets propped up a mile down the road. You rely on your senses. My senses tell me the door is locked. This doubt came about from my imagination, not from my senses. I don't need to trust what comes from my imagination, because I'm not here to entertain people. If you're writing a book and you wish to scare people, you can use your imagination to scare people. But just locking your door and going to work is not that time. So reality sensing is taking what you do normally everywhere else and applying it here explicitly. Doesn't require you to be anxious. Doesn't mean you won't be. It just doesn't require you to be. I'm happy to answer questions about that. Module 9 is the ultimate story. Sometimes we call it the reality-based story. If OCD's story has been going on for months, years, or decades, it's like the guy who went to the gym and only worked out his upper body for years. So he's really big here, and his legs are very small. We want you to go back to leg day. The alternate story is the reality-based story that had been completely missing in these moments. I've only been telling an imagination-based possibility story, an immersed event, but where's the real story? So we help you understand that there is actually a story about the obsessional moment based from your senses and common sense. So it starts with, I ran over a pothole, and it ends with, and everything was fine. And how you bridge those two is with your senses and your common sense. What did it tell me? Well, I know it felt like a pothole, not a person, and I don't have to hit a person with my car to know there's a difference. And we build that story up, we rehearse that story. Now this can sound like a giant reassurance, but what it's really doing is helping the person realize that I can broaden my attention to beyond possibilities in this moment. I can open my attention up to realities in this moment. And if everything about reality is a construction into a story, I need to have a story here, and I need to have one that can compete for its availability, because the OCD story is available. It's rehearsed, it's emotionally charged, and it's been there for years. This reality-based story needs to have a fighting chance of being available. So we rehearse it. Module 10 is just an extension of Module 2 that is more idiosyncratic to the person. You might have a very specific form of reasons or irrelevant associations, or sometimes referred to as apparently comparable events or experiences that is particularly salient to you. One of these could be better safe than sorry. How many clients are falling prey to better safe than sorry? It's a sticky one for people with OCD, because if you're already living inside of consequences, that you could be a murderous villain about to bury bodies in your backyard, living inside of that consequence does feel like better safe than sorry makes sense. But in order for better safe than sorry to make any sense in reality, there must be a threat or a danger that is demonstrable. You must have something in the here and now that says better safe than sorry is a valuable way of interacting with the world. So we find all the different con artist tricks that might pull you in and help you put them into its proper categorization and context. The real self is the opposite of the feared self, where we are intentionally having you, much like reality sensing, you're reality sensing yourself. Who am I, and how do I know who I am? Now, we're not doing this as a global who am I, Ericksonian exploration into identity development. We're doing this discreetly with OCD themes. You think you are this highly specific, dangerous person here. But who are you really, and how do you know that? And it's knowable information. We don't have to sit here and go, oh, well, guess I have to tolerate not knowing. In this model, that wouldn't be the proper use of treatment. Because you can know and you do know, but you doubt. Last one is mastery and relapse prevention. Pretty typical of any treatment. It's, can you do this on your own? Can you teach this to someone else? Do you know the material so well that you could run a 3-hour lecture? I hope so, because you're not going to be in therapy with me for 10 years. And you need to be able to sort of have another developmental moment in your life, like having a child, and not get influentially confused again. Everyone else here is good too. Next slide. Okay, let's take a breath. Any questions before we go into something?
I wanted to ask you about sexual orientation OCD, sometimes referred to as HOCD, and specifically how sort of checking your senses can be confusing for the client, in that sometimes they might consider lack of arousal as that's my senses and it's telling me something important, versus also there's sometimes a groinal response, you know, sort of they're aware of arousal and then they use that as data as, you see, that does support my feared conclusion.
And what other conclusions does it support? Which would be argumentative and not the intention of the question. question. But yeah, you're right, those have to be explained.
Right.
Right, when a person with harm OCD or pedophilia OCD says, but I had a grown-up response, that needs to be explained. We don't just go, tolerate that, no.
Yeah.
We have to understand non-concordant arousal. We have to understand the difference between arousal and desire. Those are two very different states, two very different processes. Anyone who's ever worked with rape or sexual assault survivors knows the difference between arousal and desire. Those are quite different. And it's not hard to explain to people. Right? Any 14-year-old boy who doesn't stand up at the end of Spanish class knows the difference between arousal and desire. Spanish is sexy.
So I've been told.
Probably not why I need to sit down for 5 minutes. And if we can use humor, it can go a long way. But it has to be explained. Absolutely. We can't ignore those pieces of information. So sensory information cannot be used out of context. Helping them realize it's out of context is key. And then helping them understand that there are numerous stories your use of that sensory information can support. Why are you picking this story? And then 1,000 others. Let's come up with 10 others. Right? And so that's how we would want to contextualize that kind of sensory information.
Can you talk a little bit about faith, scrupulosity, because we don't have a lot of sensory conclusions to draw on that?
Yeah.
How would ICBT work in that way?
Yeah, well, that could be a whole conference itself, right? ICBT applied to the invisible. Right? So we're often trying to help the client realize, a couple of things, in my opinion, which is, when did your faith practice change? Because it almost certainly has. How has it deviated from your normal group's practice of that, which is 10, let's say, sort of, what is 80% of your faith community practice, which is probably how you practiced, and then you changed. Tell me the story about the change. Why the change? Because inside that story, I think you find inferential confusion. You find a personalized version of a religion that previously wasn't personalized, not in that way. But it's a sticky area. And again, I always think involving clergy or other faith people involved is useful. So I'll avoid going into too many more details because I want to get to my rest of the slides, but that was a taste. Yeah.
How, with reality sensing, I can imagine a client with OCD doing that in a compulsive way. So how do we help them not engage in compulsive reality sensing?
About 15 years ago, there was a person who wrote on the ACBT listserv. I don't know if anyone was reading it back then. My client has done 50 exposures this weekend, and they wonder why they're not better. What's the answer to that question? The exposure wasn't being done to learn something, it was being done to get rid of obsessions and had a rebound effect. Any treatment can be compulsive. Mindfulness can be compulsively used, cognitive diffusion, exposure therapy, even response prevention. So I think a therapeutic issue, if you understand OCD as a specialty, not just ICBT, just the phenomenology of OCD as a disorder, you have to understand how it wants to use everything as a secret handshake to get rid of suffering. And then make sure they're not doing that. But here's the other good news. Our clients know. Just ask them, are you doing that compulsively? They're going to be like, because they know. Right? So the best source of information is the client. It feels like that might be compulsive. Are you doing that compulsively? Yeah. Okay, so how would we augment this so you're not doing it compulsively? So the same use you would give to ERP, ACT, or any other treatment, if they might use it compulsively, applies to this. Any other questions before we move on to data?
Sorry, maybe a tiny question, but they're very intentionally called modules, not sessions. And so I'm wondering, realistically, in a clinical setting, assuming you have some engagement to get to start ICBT, how long are you seeing this take?
Personally, 4 to 6 months minimum.
Okay.
but I don't see easy cases anymore. I see the people who dropped out of Rogers twice. If I was an intern and I got fed a straightforward case of OCD that just developed last week, probably a lot faster.
Okay,
The trial data is anywhere from 20 to 24 sessions.
okay.
24 sessions was for the people with overvalued ideation. The most recent non-inferiority trial that's already wrapped up but is being sort of synthesized right now is 16 sessions.
Okay, thank you.
So it's on par with you.
Sure.
Other questions?
How do you increase motivation to do this? Because I tried to do this with somebody who really fit this model very well, and she kind of resisted. I'm probably horrible at doing it. I read an article and thought like, hey, let's try this approach. But she was like, nah, it's not going to work.
Well, the secret is we're all horrible therapists. I would recommend training and consultation, but I do that for any treatment approach. I would see the need to convince them it's the problem, right? Meaning that's the work.
Oh.
Not trying to convince them, trying to figure out why you need to convince them, right? So it's, I'm not here to try to sell you on something, right? You have a problem, you want to get better. I'm suggesting there's a really powerful way to get better, but something's getting in the way of that. Let's explore that. So if I can steal from David Burns, which I'm not that big of a fan of stealing from, he talks about outcome and process resistance. I prefer the word ambivalence because it's very MI oriented. Can you resolve the outcome and process ambivalence about this approach? Because the chances are they're going to have this ambivalence with any treatment, including medications. So the issue isn't ICBT or ERP or Lexapro. The issue is that something's getting in the way of treatment generally. So we want to work on those more general therapeutic issues. Does that make sense?
Yeah.
It seems like in the modules, I believe at the beginning of it, the intervention module, that starts at module 5. I could be wrong, but I'm curious about how you go about symptom management with clients where symptoms are really pervasive and interfering, and life interference, functioning is much lower, but when you're going through modules like 1 to 10, up into the intervention modules, how are you helping your clients with symptoms?
Well, I think part of it is modeling that I'm not scared for their symptoms. Right? Now, if they're engaging in compulsions that are harming themselves or others, right, they're wiping their baby too much and it's causing a rash, it's getting infected, we might need to do more explicit response prevention. But I don't find that to be most cases of OCD most of the time. Those would be outlier cases, I think. So I think if I can model that, I'm not scared of you having obsessions or compulsions, and you've probably lived a really long time by the time you've gotten to therapy with me with these compulsions. I don't need to treat them like urgency. I don't need to jump on the urgency train with you. I can go, well, yeah, that's really